for those of you that are around the west side of Columbia,
recording in progress.
Boy, what an adventure that was. We had about an hour and a half ago or so with that earthquake, right? Wow. When they were happening over in Elgin, we could feel them over here, but this one, according to everything I read on the internet about an hour and a half ago, was right.
I can't hear you, sir.
Oops. Hang on. Okay, you should be able to hear me. My microphone is saying it's on. Can anyone hear me? Okay.
Yes.
We have people who are hearing. Oh, okay. Okay, thank you. Everything on my end is showing that my vocal is going through. So, all right, maybe it's here. You know what, guys? Hang on. I'm going to take a second. I'm going to put up in the chat. All right, maybe his speakers are off or something. That's the only thing I can think. But anyway, so yeah, it was quite an earthquake. I guess it happened right near the dam, from what I've read, in Lake Murray, and really shook my house, at least pretty significantly. So if that was a 3.0 on the Richter scale, I can't even imagine what the people of San Francisco encounter when they deal with a 9. No thanks. No thanks at all. So anyway, all right. So we're going to go ahead and pick up and conclude today our content on the respiratory system as promised. As I said, this is a really important lecture when it comes to content for exam number 2. You'll notice that there's a significant amount of material in today's lecture that you are going to need to know, certainly some definitions, some new things that you've probably never been exposed to or heard of before. Again, not overly difficult. I'll explain them to you and we'll make sense of them so that you're comfortable. But there is a good amount of content in today's lecture that will be represented on your next lecture exam. All right. So will everyone please check your microphones? I can hear an open mic for sure. Somebody please check and mute. Okay, there we go.
Dr. Fine.
Yes.
I'm sorry. Is there any way you can, because I know you said that we'll be going over the third picture for the exam today. Can you remind us of the first 2 that's going to be on the exam? The first 2 pictures?
Sure. As I've said previously, the one was from cardiovascular, and those were the walls of the heart. The second one we covered last time around, and I can't honestly remember what that one was. Does anyone remember what the second one was we covered in respiratory on Tuesday?
Names and functions.
I'm sorry, go ahead. Go ahead, Sweeta.
Say that again, whoever knows what it was.
There is like the conducting zone passages. So you have to just remember the names and the functions. Like it's the chapter, it's the same chapter, respiratory.
Yes. In fact, let me just slide back. You're right. Here we go. Conduction zone passages, chapter 22.
Okay, I have that one. Thank you.
Those are the 2. Yep, no problem reminding. No problem at all. And like you said, you're absolutely accurate, Janice. You'll be getting the third one today in today's lecture, okay? And I'll stop and explain what you need to know about it when we get there. So speaking of the exam, today wraps up our content. We had 3 lectures on the cardiovascular system. This is our second lecture now on the respiratory system, and it is those 2 systems that will make up the content for exam number 2. Okay, so that means looking at our calendar, and again, you guys have these calendars, so don't email me next week about it. Okay, this isn't high school. You have to be responsible for time management and accurate scheduling. That's why I give you the calendars. But next week, just as a reminder in advance, next week, Tuesday, when we normally would meet for lecture, we do have lab. However, we do not have lecture that day because that's your study day, as your lecture calendar says. Lab calendar says we do meet for lab, though. And I'll send out an email, but just so you're prepared, we'll be meeting at 2:20 and we'll just dive right into lab. Okay, and that's going to be on the respiratory system. So you'll have that secondary dose of respiratory system before you take your exam, which is really important. It'll help you do better on that exam. So next Tuesday is that day that I give you, that dedicated study day, because I know how busy all of your lives are. Okay, you all have families and jobs and other classes and lots of demands. I remember what it was like well. So that's why I very purposefully build into the calendar that built-in, very intentional study day, the class session before the exam occurs. So at the very least, you have that carved out time when we otherwise would be meeting, that you could sit down and have that hour and a half to lay out the material in my presentations and create a workable study guide so that you have time to thoroughly prepare. It's done with 100% intent of helping you guys to be successful and realizing the demands that you have in your lives outside of Bio 211. Okay, so that is your study day next week, Tuesday. All right, next week, Thursday, 1 week from today, will be exam number 2 here in lecture. And that exam, just like exam number 1 was before it, will be open from 8 a.m. to 8 p.m. It'll be true, false, multiple choice, and 3 matching questions. We've talked about the first 2 already. We'll talk about the third one today. And you'll take that on Thursday, 1 week from today, March 5th. All right. That following week happens just by coincidence to fall as spring break. So obviously we do not have class during spring break that following Tuesday and Thursday. So after today's lecture, lab, we meet on next Tuesday, and I'll send a reminder of that on Sunday. Okay, but for lecture, the next time we meet here via Zoom for lecture will be Tuesday, March 17th, as indicated on your calendar. Okay, and we'll start into the digestive system then. So next week is study prep, and then the exam, Tuesday, Thursday. The following week is spring break. Okay, and then we're back for digestive system. So let's go ahead and dive into respiratory system. As you know, we started with the first half of chapter 22 on the respiratory system on Tuesday. We went over the anatomic parts and components of the respiratory system. We broke it out categorically by the upper respiratory tract versus the lower respiratory tract. And then we talked about the conducting passageways, the pharynx, the larynx, the trachea, the entire bronchial tree. Then we talked about the respiratory portion of the respiratory system, the lungs and the alveoli. We talked about the serous membranes, the lobes of the lungs, etc. Okay, kind of a nice overview of the respiratory system that's really important to understanding the physiology. How does it work? How do we breathe in and out? And this lecture is actually one of my favorite to teach. And I remember way back years ago when I was in med school, when I first learned how we breathe, and it kind of blew my mind a little bit, to be honest with you. If you really went out and just started asking people on the street who haven't taken an anatomy class or aren't in healthcare, particularly in respiratory care, most 99% would give you a wrong answer on how do we breathe? How do we inhale air and how do we exhale air? Okay, most people say that our lungs contract and that's how we push air out. That's how we exhale. And then, like a vacuum cleaner, we use our lungs to pull in air from the world around us, from that external environment. okay? And they couldn't be more wrong, okay? And that's why I really like teaching this lecture, because I get a lot of good feedback on this lecture, that it really was informative and that students learned something completely new to them that they really never even had any inkling was how things worked. So to that end, I'm going to start today by sharing and reminding of two very basic scientific concepts, okay, that are really key to respiration and the physiology of the respiratory system. Okay, for many of you, this might be a refresh back to Bio 210. I know in my 210 sections, I talk about these concepts. But for many of you, it may take you even further back, perhaps even all the way back to high school or middle school, since you've heard of these. But it's important that we dust off these two pretty basic concepts, but they're important to understand because they really factor into what you need to know about how the respiratory system works physiologically. All right, so the first one of those two key concepts is the scientific rule that gases always move from an area of high concentration or high pressure to an area of low pressure, okay? Gases always move from an area of high pressure to an area of lower pressure, okay? So if I had, for example, 2 jars of water in front of me on my desk, and there was a glass tube that ran between the two of them, and one of the jars was filled 3/4 full of water and the other only 1/4. Immediately, that water in the 3/4 full jar would start to lower, and that water would go through the tube until both of them were equally full, and then it would stop. That's an example of, in science, things want to move down an area of higher pressure to an area of lower. And then the second phase to that is what I just shared. What makes it stop? What makes it stop is when they've reached balance, when they've hit equal, okay? So if an area of high pressure, gases escape and move to an area of lower pressure, they'll only continue to do that until that area of lower pressure is equal to the pressure in the original area, and then it will stop. That's going to be really important to remember, and I'll remind more about it as we're going through the lecture today, but it's an important concept of how our lungs work. All right. The second scientific concept is probably even a little bit more basic than that one. And that's that if you take a compartment or an area and there are gases or whatever inside of it, it could be liquid or gases inside of it, okay? And if you take that container and you somehow forcefully make that container smaller, it's going to increase the pressure inside of that container, okay? And then the opposite, of course, is true. If somehow you took that container and you could stretch it and make it larger, the gases inside, the pressure inside would reduce. It would become less. It would become lower. Okay. The example of that is a pretty easy one. Think of a can of soda, a 12-ounce aluminum can of soda. What happens if you squeeze that can, right? If you start to dent and squeeze that can, you're obviously making the area, the physical space within that can smaller, and therefore the pressure of the fluid inside is increasing. And if you continue to do that long enough, it's going to burst, right? Well, the same would be true if you could magically stretch that aluminum can. The pressure of that liquid inside would get lower as well. So that's an example. All right, so those are the two introductory dust-off type key scientific concepts. Again, I'll remind you, I'll allude back to these concepts when we're talking about the specifics related to the respiratory system, but I think it's important and it always helps to start by reminding you, or at least sharing, those key concepts first, because they're critical into how we breathe. All right, so let's start with the most obvious thing that everyone, even before you registered for this course, you knew. How do we breathe? And you're going to see today in the lecture a number of fancy terms, okay, titles that for something that we already knew. In this case, pulmonary ventilation is a fancy term for breathing, okay? Pulmonary ventilation is just breathing, all right? We have inspiration or inhalation when we breathe in and we pull gases into our lungs from the external environment. And then the opposite, of course, is expiration or exhalation or breathing outward, having gases leave from our lungs out into the environment. Okay? Real easy. You guys knew that before we started the class, obviously. All right, here, now we start with some definitions, okay, and some concepts that are going to lead into how physiologically do we breathe? How do our lungs and our alveoli work in tandem with the pressure in the atmosphere around us to make us inhale and exhale and thereby have effective gas exchange within the human body? All right, the first thing that we have to understand is atmospheric pressure. All right, so atmospheric pressure, to make it very, very simple, atmospheric pressure, when we're sitting here listening to this lecture right now, there are gases, invisible, but gases all around us, okay? Oxygen, right, among many other type of gases and components of the gases around us, okay? But there are gases all around us right now that are exerting some degree of pressure on us, okay? And, you know, an example of that would be for people who go scuba diving, okay? And if you don't scuba dive, like I don't scuba dive, but you've at least heard of this probably from television at the very least. But people who scuba dive sometimes get at risk if they dive too deeply, too fast. They end up having a condition called the bends, where they start to have respiratory distress because, and it's very life-threatening, and it's because the pressure down below sea level is so much more intense than it is at sea level. Their lungs and their body haven't had a chance to adapt to it. So it ends up causing sometimes fatal consequences. Okay, so there's a severe difference in the pressure down below sea level than there is where we are at sea level. Okay, and then the opposite of that is if you went out to Colorado and were on the top of one of the Rocky Mountains, okay, you would have severely less pressure around you because the air is so much lighter up there. Okay, and so pressure around us, that atmospheric pressure, the gases all around us, are measured as a baseline value of being at actual sea level. At ground sea level is considered quote unquote normal. That's considered 1 atmosphere. You don't need to know that. I'm just trying to illustrate what atmospheric pressure is and the fact that it can change, okay? So it's just the air around us. So then our respiratory pressures are described as being compared to atmospheric pressure. If we have what's called a negative respiratory pressure, the pressure inside of our pleural cavity within our lungs and alveoli are going to be lower than the pressure out in the atmosphere around us. If we have a respiratory pressure that's positive, in that case, our alveoli and lungs are going to have a pressure higher than the pressure in the atmosphere around us. And then there's a third variable or measurement that's important, and that's just balance, 0 respiratory pressure. That's where both our pulmonary pressure, our respiratory pressure inside of our lungs is exactly equal to the pressure in the atmosphere around us. So all three things can be the case, okay? We can have less pressure in our lungs, we can have more pressure in our lungs, or we can have equal pressure in our lungs to the atmosphere around us. And that's all very important. All right, so here's a term that you're going to need to know. And again, for the exam, you're going to see that there are several things where you're just going to need to know the basic concept, the definition of what does it mean, okay? This first one is going to be what's called intrapulmonary pressure, okay? Intrapulmonary, meaning inside of the lungs. And remember, we have over 300 million alveoli that comprise by far the vast majority of the mass of our lungs is alveoli, okay? So we can define or label that intrapulmonary pressure as the air pressure that's within those alveoli. That's what I need you to know, okay? And then know that, I mean, just for understanding our lecture today, that intrapulmonary pressure, the air pressure within those alveoli, changes when we breathe, when we inhale or we exhale, right? I think that's very obvious. We all know that our lungs and with it, our alveoli will change shape and size as we inspire air or if we expire air. But know that, like I said, when I talked about the gases moving down the pressure gradient until they equalize, know that with breathing and with respiration, our intrapulmonary pressure always eventually hits equal or balance with the atmospheric pressure. And then that stops the event that's going on and we change gears and the opposite thing occurs, okay? So what I mean specifically by that is if we're inspiring air, we're inhaling air, and eventually then while we're breathing in, our atmospheric pressure and intrapulmonary pressure will hit equal. That's what's going to trigger our autonomic nervous system, our receptors and our brainstem to say this is equal. And then we're going to stop inhaling. And for that very minute second, they're going to be equalized and nothing's going to happen. And then very rapidly thereafter, we're going to start to what? We're going to start to exhale, right? And then we're going to exhale air until pressure in the atmosphere is equal to intrapulmonary pressure. And then once it's equal, it'll stop for a brief second, and then we'll go back to inhaling. Okay, so that's why these key concepts of gas moving down the pressure gradient only until they equalize is critical to understanding all of this. All right, the next term is called intrapleural pressure. All right, and this one again is pressure inside of the lungs themselves, and this has to do with air that remains in the lungs after we exhale. Okay, and remember I said when we were talking about respiratory anatomy, I said that we never ever want, and barring something catastrophic, we never encounter our lungs being completely empty. Our lungs don't go flat like a balloon could. There's always some residual, some leftover air. When we exhale, even if we exhale with all of our might, we're going to stop short of emptying all of the gases out of our lungs. And that's to always at least partially keep our lungs inflated so that they can perform properly. If they went completely flat, like someone that gets stabbed, for example, and they have a deflated, punctured lung, that lung goes completely flat. It has to be surgically repaired and then inflated again, almost like a balloon to get it working again. Once it's flat, it doesn't just fix itself. Okay, so it's a serious situation. Later on, we're going to talk about, in this lecture today, we're going to talk about pulmonary function testing. and some of the measurements that we use in healthcare to determine and ascertain different respiratory diseases like COPD and asthma and lung cancer. You know, we measure normal, quote unquote, healthy lungs compared to an impaired respiratory function. Okay. One of the pressures we're going to talk about is this negative pressure that always remains in the lungs after we exhale to keep the lungs inflated. All right, let's talk about some naturally occurring, because of the anatomy that we talked about last time. There are two inward forces that affect our lungs themselves that make them always just naturally want to get smaller, which is really important because we know our lungs, much like a balloon, have to expand as we inspire air, and then they have to contract. They have to get smaller when we expire air. Okay, they change size to accommodate gas movement. Okay, there are two forces that naturally are always prompting those lungs to want to pull back and get smaller to their original size. And both of them we talked about at length last time. And the first one is the lungs, what they're actually constructed of. Okay, remember our lungs, the stroma, the tissue that is the surface of our lungs themselves, are made up of, remember we said, elastic connective tissue. Okay, and that elastic fibrotic tissue has all those elastic fibers in it that have a natural disposition to snapping back into place. Again, like our skin, if we pull it away from our body and let go, our skin, because of that elastic type connective tissue, it's going to snap back into place. Same with our lungs. Okay, so we talked about that last time. We also talked about the second inward force that always is working to keep lungs small, and that's the surface tension. Remember, we talked about the type 2 alveolar fluid, that surfactant that is released to make water, which is a waste product of gas exchange at the alveoli level, make that water run off so it doesn't deflate or collapse the alveoli. All right, that surface tension, those alveoli, remember, are paper thin, simple squamous epithelial tissue, and they're always coated in fluid. Okay, they're extremely fragile and they're coated in fluid, whether it's water from waste product or whether it's surfactant. There's still some fluid on those alveoli, and that weight always has a effect of wanting to collapse those paper thin alveoli. Okay, and because the vast majority of mass of our lungs are alveoli, there again is a secondary force that's always trying to shrink down and collapse our lungs in whole as a whole. Okay, so it's the elastic composition and the fluid that are always trying to pull our lungs back to their original size. All right, pulmonary ventilation, inspiration and expiration. Okay, how do we inhale air? How do we exhale air? These are mechanical processes that have to do with muscular contraction. Okay, and this goes back again to my second scientific principle that I talked about. If we change the size of a compartment, if we make it smaller, the pressure inside will intensify. If we make it larger, the pressure inside will weaken. Okay, and these changes always move until they equalize. All right, so if we change the size of the thoracic cavity, if we think of our thoracic cavity as that compartment instead of the 12-ounce soda can like I told you about, if we change the size of the thoracic cavity, which as we know from the anatomy that we talked about on Tuesday, the vast majority of the thoracic cavity is lungs, and within the lungs, alveoli. Okay, we're going to change the pressure within our lungs and within the alveoli by changing the size of the thoracic cavity. And if we change the pressure within the cavity, we're going to have gas flow one direction or the other until they equalize. And we'll get into the specifics of this on the coming 2 slides. All right. And then just so you know, again, in between breaths, when the thoracic cavity hits equal to the atmospheric pressure outside of our bodies, we stop inhaling or exhaling, and then the next process starts up, like I described earlier. Again, it only lasts a second, but that's what stops and changes gears. Remember, and we're going to talk later about this, that the respiratory system is a very unique system in that it's one of the few where we have conscious, voluntary control of it. We can make ourselves breathe very rapidly. We can make ourselves hold our breath. Okay, so we have conscious control of our respiratory system. But 90% of the time, probably 95% of the time, we're not thinking about our respiratory activity at all. So we also have autonomic nervous system control of our respiratory system. So when we're sleeping or we're listening to lecture, we're not consciously thinking, breathe in, now breathe out. Our autonomic nervous system takes over. So the respiratory system is very unique in that it has both autonomic nervous system control of it, where we don't think about it, but then we also consciously can control it if we want to. Okay? It's during that autonomic nervous system control where those pressures hit and the receptors will signal for our brainstem to now inhale. Okay, now pressure's equal, now exhale. All right, so let's move specifically now to how do we inspire? And you can see this is important, and I'm going to explain this. You're going to know this for the exam, and I'm willing to bet no one is going to get this wrong on the exam because this is the key topic for today. Okay, when we inhale, when we inspire air, it is related to muscle contractions. 2 different muscle groups, but contracting make us inhale air. The first one is our diaphragm. Okay, and if you remember, when we talked about the anatomy of the respiratory system, I mentioned that the diaphragm muscle, while not directly a component of the respiratory system, it is certainly a secondary player to the respiratory system, and that we would be talking about the diaphragm's involvement when we came to this lecture today on respiratory physiology. Remember that diaphragm is a muscle that lies right under the rib cage and is the magic divide line between the thoracic cavity above it and the abdominal cavity below it. Okay? Key to understanding what the diaphragm muscle does is remembering the position of the diaphragm muscle. When the diaphragm muscle is relaxed, it is making a U shape. Okay, it's a dome shape. It takes on the shape almost of our rib cage at the bottom. Okay, so it is a dome shape pointing upward. Okay, and that's really important because when it's time for us to breathe in air and inspire, that diaphragm muscle is going to contract. And when the diaphragm muscle contracts, the diaphragm muscle moves downward and flattens out. So in other words, that dome, that hill shape in the shape of your rib cage gets flat and the diaphragm moves down technically into the abdominal cavity a little bit. Okay. And when that does that, of course, it was a dome shape up tight to the ribs, and now it moved down 4 inches and flattened out because the diaphragm contracted. We have now expanded the thoracic cavity's volume, right? We've added space by the diaphragm moving downward. All right, secondary to that, and at the same time as that, our intercostal muscles, which are the muscles that attach to our rib cage and our sternum, okay, they're going to contract at the same time. And when our intercostal muscles contract, they're going to pull our ribs and our sternum, our entire thoracic cage, upward and outward. And that, of course, also expands the thoracic cavity space. So we have the diaphragm on the bottom of the thoracic cavity flattening out, expanding the thoracic cavity volume and space. And then we have the intercostal muscles pulling our rib cage up and out, away from our body, expanding the thoracic cavity's volume and space. All right, so based on what we've talked about so far, you can see where we're going here, right? That thoracic cavity now is much larger than it was a second and a half before these muscles started contracting. So when that thoracic cavity now is much larger, the pressure of the gases inside of the thoracic cavity within our lungs and alveoli is going to dramatically decrease. Okay? And when that pressure decreases, we go back to my first scientific principle. What happens? Gases at a higher pressure move into an area of lower pressure. We have just significantly lowered the pressure within that intrapulmonary pressure in our thoracic cavity. And so our atmospheric pressure around us outside is now much higher. So that air, the gases around us, are going to rush in through our nasal passages and in through our mouth and down into our lungs. And they're going to continue to rush in until the gas pressures are equal in the atmospheric pressure and in our intrapulmonary pressure. And then we'll stop inhaling. That's how we breathe in. There's no vacuum cleaner like effort. It's merely a changing of the size of our thoracic cavity, lowering the pressure in that cavity to that is lower than in the atmosphere, and then gases do what they always do, and gases in a higher pressure area rush into that lower pressure area only until they're equalized, and then they stop. And that's how we breathe in. And as you can imagine, this next slide says the exact same thing, what I just talked about, okay? So it's the same thing. And then expiration or exhalation, breathing out, is the exact opposite, okay? In this case, both of those muscle groups are going to relax, all right? And when the diaphragm muscle relaxes and that diaphragm muscle moves back to its dome shape and starts to move up and compress the thoracic cavity, and the intercostal muscles relax and they let that rib cage and sternum sink back down tighter onto the body, both of them are going to make the thoracic cavity smaller. The volume gets smaller. And remember what I said about a cavity or a compartment, like a soda can. If you make it smaller, the pressure within it increases. So now the gases that are intrapulmonary pressure now has increased significantly because now we have a much smaller volume of our thoracic cavity. And now that intrapulmonary pressure is higher than the atmospheric pressure outside of the body, and gases rush from our lungs out into the atmosphere. Again, only until they hit equal, and then they stop. And then we switch gears and it starts all over. So that's how you breathe. You breathe in and out, not by blowing, not by acting like a vacuum cleaner. It's by your two sets of muscles changing the shape of your thoracic cavity, and then gases rushing from an area of high concentration to an area of low concentration. That's how we breathe. And again, I know I'm a science nerd. I admit it. I know it. I like that kind of stuff. But that to me was, I remember way back, I'll never forget when I first heard that. I thought, wow, I never thought that's how we breathe. So I learned something interesting. All right, let's move on. So that's how we breathe in and out, guys. Now let's talk about healthy respiratory organs and healthy respiratory function. Okay, we'll first talk about the organs themselves, and that's the lungs themselves. We're going to talk about a term called lung compliance. That's going to be important for you guys to know and understand for the exam. Fortunately, we've talked about this before. When we talk about lung compliance, we are just measuring, we're trying to estimate or determine how healthy is a patient's lung tissue itself, not the function, not in the amount of gas that can move in or out. We'll talk about pulmonary function testing in a couple of minutes, but this is the lung tissue itself. All right. And it's just simply a measure of how much that lung can stretch, because remember, lungs stretch. They're made of elastic connective tissue, and they have surfactant and alveolar surface tension that we've talked about now 3 times, that are always wanting flexibility. A lung has to be able to change shape. Unfortunately, for some people who have COPD or stage 3 lung cancer or severe chronic asthma, for example, severe allergies, things that affect respiratory distress, they don't have the normal lung compliance that someone otherwise healthy would. Their lungs don't stretch the way that they once did. Okay, so that's all lung compliance is. It's lung compliance is based on the fact that the stroma is made of elastic connective tissue, and that there's alveolar surface tension. All right, you have 2 quiz questions today because we split this chapter, as you guys know from last time. So the choice is below. What is the determining factor? What determines the direction of gas movement in and out of the lungs? The temperature, molecular weight and size of gas molecules, or the pressure gradient? And I'd be very deeply disappointed if anybody got this wrong, because that would have been the last 15 minutes I have talked in absolute vain. All right, let's move on. All right, so now let's get to assessing actual ventilation, the amount of gases that we move in and out of the lungs. Lung compliance was the stretchability of the lungs, physically, the tissue. Now we're talking about volumes, okay? And some of you, very likely, may be heading into respiratory therapy. And for those of you that are heading down that career path, you're going to be dealing with this a lot in your careers, okay? For others, some of you, myself included, you may have had a pulmonary function test or a respiratory capacity test at some point in your life. If you've had one, you'll never forget it. And I'll describe why in a couple of minutes when we're talking about the volumes, okay? But we measure the ability of a patient, and specifically their respiratory system, to move gases in and out of the lungs as a measure and a method of estimating or determining their respiratory health, okay? If someone comes in and has symptoms of asthma or symptoms of COPD, okay, they're going to be given a pulmonary function test as one of several tests. And their ability to move an adequate volume of gas in and out of those lungs is going to be a huge clinical tool, an assessment metric that's going to allow us to say, yes, you do have impaired lung function, you have COPD, or no, you have completely normal lungs, you don't have asthma, okay? And how we measure that, the test is called spirometry, okay? It's also referred to, as I use more often, as a pulmonary function test. A PFT is probably the most commonly used term in the real world in healthcare, Okay, a PFT is a pulmonary function test. We're looking at how the pulmonary, the respiratory system or a respiratory function test is functioning. All right. But the old style spirometers from decades ago were actually meters, much like a blood pressure cuff, that gauge that's attached to a blood pressure cuff. And the respiratory tech would have that gauge in his or her hand, and they would have a tube attached to it, and the patient would be instructed by the respiratory test during the pulmonary function test to exhale and then inhale according to instruction that we'll talk about in a few minutes here, while they obtained their clinical measurements. Okay, and those measurements were obtained from that actual mechanical gauge. Okay, nowadays, of course, they're very much electronic and computerized, okay, that do these, but respiratory techs still are very much a part of doing pulmonary function testing, okay? It's just that the computer collects the data instead of manually connecting it from looking at a needle on a gauge. All right, so let's look at an output chart. And this looks a little bit like an EKG that we studied and learned about over in the cardiovascular system, which, if you remember, was a tracing of the electrical activity of the heart. In this case, this is a tracing of the inspirations and expirations, the gas volumes being inspired and expired by the patient, and then put into a tracing like pattern so we can analyze. These are data points that we can use to assess clinical functionality. Okay, you can also see that this is underlined and highlighted. So guys, this is your third matching question for exam number 2. All right, right here, this is it. Now, make sure you're listening to me right now. You do not need to know any of the numbers on this chart, okay? These numbers are just an example. They're just an example of what a patient may do to show you, when I'm explaining to you what each of these things is, it's going to help in explaining what it is we're measuring. The numbers are completely made up, okay? In fact, they're not the same for everyone at all. They depend on your age, your health, your body weight, all of those influence, especially your respiratory health. They all influence what these numbers look like. So they're fictitious. What I do want you to know is what, and we're going to talk about in the coming few minutes here. I'm going to explain all of this to you. But what do these waves represent? And then what do the totals indicate? What are we measuring? Okay, so understand what it is, the title of what we're evaluating, and what it is we're evaluating. All right, so the output is called a spirograph, okay, or again, much more commonly, a pulmonary function test. All right, so what we're seeing here, let's start by what we're seeing on the tracing, on the data that's been acquired. All right, so as the patient sits with a tube in their mouth, and again, now it's more computerized, but as they inhale, that line, that tracing is going to go up until they stop inhaling. And then they exhale, the tracing will go down. And then it will go up, and then it will go down. And it varies depending on how deeply someone breathed. Here, someone only inhaled a little bit on this curve, but they inhaled a lot right here. And that's what we're measuring, okay? All right, so that's what up and down mean in the waveform. All right, so that's the first part. The second thing to start with, where I always start, is with what's called tidal volume, okay? And you definitely need to know what this wave is, and it's called tidal volume, and what tidal volume means. That's what I want you to take away from these things we're going to talk about, okay? Tidal volume is the breathing pattern of the patient while they're at rest, Okay, so right here, this patient is just sitting, they're breathing in, they're breathing out, they're breathing in, they're breathing out. And that's why it's this very narrow bandwidth of light blue. It's your normal breathing like you and I are doing right now, sitting here. Okay, so that's just at rest breathing. It's called tidal volume. Don't forget that. All right, now I'm going to use the analogy now of someone going through a pulmonary function test because that's where this is acquired. Okay, so what happens during a pulmonary function or a respiratory spirometry test is the patient will record a minute or so of resting tidal volume to get a baseline. All right, and then that respiratory tech, and this is where I said if you've had a pulmonary function test, you'll remember having had one because it gets pretty intense. And these respiratory techs do a tremendous job, but they have to become sometimes pretty aggressive to push someone to their max. Okay, so at the right here, if this patient is inspiring and expiring into that tube, and now that respiratory tech is going to say, now I want you to do a maximum inhalation for as long and as hard as you possibly can. And so then that patient is going to start to breathe in as hard as they can. And that respiratory tech, they're going to feel like quitting. And the respiratory tech, it's real important that the respiratory tech pushes them to the absolute max that they can perform in order to get accurate data. So that respiratory tech is going to be sitting there shouting in their ear, keep going, harder, further, keep going, go, 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 go. And they're going to go all the way until they see blue dots and you feel like you're going to pass out. Okay, that's why I said you'll always remember having had one of these if you have. All right, and then within a millisecond, that respiratory tech is going to tell you, now start exhaling with as much force and for as long as you can. And that's what we're going to see here. Down, 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 way below resting value. And they're going to exhale, and she or he are going to be telling you, keep going, keep going, keep going, again, until you feel like you're about to pass out. Okay? And the reason they do that is exceptionally important, again, in order to acquire accurate data on lung health and lung ability and capacities. All right, so tidal volume we talked about. So during that maximal inhalation that we started with right here, that level of oxygen that we can pull in, the quantity of gas above what we inspire when we're at rest is called the inspiratory reserve volume. It's the capacity of our lungs. How much gas could our lungs pull in above what we do at rest? That's inspiratory reserve volume. It could real easily be called, and maybe in some ways should be called, inspiratory reserve capacity. How much could we if we're not using it? Okay, and it's a measure of lung health, as you can imagine. If you're healthy, you may get 6,000 milliliters. But if you have chronic COPD, you may only be able to inspire 3,500 milliliters because your lungs aren't as functional. Okay, all right, and then the same thing holds true as we have the exhalation, that maximal exhalation. The same opposite of inspiratory reserve is this volume. How much air can we expire during maximal exertion beyond what we do at rest? And that's called the expiratory reserve volume, or it's the expiratory reserve capacity. How much room is there in our lungs beyond what we use at rest? And then underneath it in the green is back to a topic that we've talked about already, that negative pulmonary pressure that always keeps our lungs partially inflated. That's to say, this is the excess oxygen or gas that never gets eliminated from the lungs, that keeps our lungs inflated even after we try our hardest to push all the air out. All the air never leaves our lungs, so they always remain partially inflated and ready to act again. That's called the residual volume. It's the volume we never touch. It's like a savings account of gas. Okay? So those are the main volumes that we can determine and we get measurements of during a pulmonary function test. The others, much like we did over when we talked about the cardiovascular measurements, where we can use these volumes and add them together and combine them to come up with others. How we came up with stroke volume, for example, and cardiac output. Remember, we had other variables that added together to make those. Okay, in this case, if we add the amount of air we breathe in during tidal volume, and then all the capacity that we could bring in with maximal exertion, we add those together, that's our inspiratory capacity. It's the maximum amount of air that we could pull into our lungs. Okay, and then if we take the inspiratory reserve volume, the max we could pull in, the expiratory reserve volume, the max we could push out, and all of those are beyond rest, and add them to our resting normal volumes, that gives us our vital capacity. That's the most air that we can move in and out of our lungs with force. Like during one of these extreme tests. Okay, and then if we take that vital capacity, the maximum amount of air that we can move in and out of our lungs with force, and add that small reserve volume that never leaves our lungs to keep our lungs inflated, the residual volume, that becomes our total lung capacity. Don't worry about functional residual. You can see it's just it's a combination of expiratory reserve and the residual. Okay, it's everything that could potentially be eliminated below tidal volume. Okay, so those are the things I want you to know for the matching question. Now, as you guys go to study for this exam, okay, and look at this matching question, everything that I've just explained to you is on the next 3 or 4 slides, all spelled out. So you'll be able to refresh. And if you have any questions as you go through this and need refreshing beyond what's spelled out for you on the coming slides, you can always, again, consult with YouTube. There are hundreds of videos out there on pulmonary function testing that will also help refresh what I just told you about if for some reason you forget. All right, so here again, these are those slides I was telling you about for study purposes. What is tidal volume? What is inspiratory reserve? What is expiratory reserve? What is residual? That amount that we don't ever expire to keep our lungs always partially inflated. Then we have the combinations that I talked about, you know, the functional capacity, vital capacity, and total lung capacity. All of these things are just exactly what I talked about while we were looking at the chart. It makes it so much easier on you, the learner, if I explain all of these things while we're looking at this chart versus just reading them to you off of a slide. These are here for you as a refresher when you're studying. All right, this slide, moving on to respiration itself, gas exchange. All right, so this exact slide we've seen previously. Okay, so this is going to be nothing more than a refresh. At this point, I certainly hope that all of this is resonating and makes sense to you guys. Okay, gas exchange occurs between blood and the alveoli in the lungs, and exchange occurs between blood and cells and tissues out in the body. External respiration is what occurs in the lungs when deoxygenated blood comes. Whoops,
You get a class now?
Yeah.
we've got
Yeah,
microphone
my class
open.
ends at 3:45.
Oh, have you been watching it all day?
We have a microphone open, guys. Somebody's child just got out of class. We don't all need to know that. Please mute your microphones. It's very disruptive. All right, let me go back now. I have to stop share, and then I'm going to share again. Guys, by this point, there's no excuse for this. You have one responsibility: mute your mic. Just do it, as Nike says. All right, I'm going to start again. External respiration is gas exchange between blood and our lungs coming from the heart. Deoxygenated blood coming from that right ventricle makes its way through the capillaries in the pulmonary circuit, meets up with the alveoli, and gas exchange occurs. Carbon dioxide is offloaded, oxygen is onloaded. Now that blood is oxygenated, and it's going to make its way back to the left atrium, where then it's going to be cycled throughout the body. In that next phase, called internal respiration, is when that blood leaves the heart full of oxygen, heads out both to the heart via the coronary arteries and veins, and heads out systemically to all the cells and tissues, and in turn drops off oxygen at the cellular level and picks up carbon dioxide, returning it to the heart, and then ultimately back to the lungs, and the process starts all over again. We've seen these slides before. I hope this is really sunk in by now. All right, let's talk about a couple of terms that you guys are going to need to know for your exams. The first one is, what is ventilation perfusion coupling? It's a pretty easy concept with a fancy name. Perfusion is the blood flow coming from the heart that I just described. The amount of blood coming from the heart to the lungs for gas exchange. Ventilation is the amount of gas making its way into the body through those conducting tubes, the bronchial tree, the pharynx, the larynx, the trachea, making their way into the lungs and the alveoli. Perfusion is the blood getting to the lungs. Ventilation is the air, the gas getting to the lungs. All right. And what ventilation perfusion coupling is all about is just measuring the rates of each of them, because our best, most efficient gas exchange occurs when the amount of blood reaching the alveoli and the amount of gas reaching the alveoli are matched up. Okay? And that kind of makes sense. It's kind of common sense. If you had too little blood going to the lungs, you'd have a decrease in oxygen carrying capacity. We'd have too few red blood cells, right? So we wouldn't have optimal gas exchange. Likewise, if you had stage 3 lung cancer and your bronchial tree didn't pull in enough gas to reach the alveoli, you would have insufficient oxygen to meet up with the erythrocytes, and you'd have less than efficient gas exchange. That's all this is saying. We want the same amount of blood and air getting to the alveoli and for efficient gas exchange, and that's called ventilation perfusion coupling or matching. Easy term. All right, second of your quiz questions. What is the matching or the measurement of blood flow compared with ventilation? This is in the lungs. All right, let's continue. All right, so we've talked about how gases are transported previously. We introduced it when we talked about blood. We certainly talked about it when we talked about the cardiovascular system, right? Oxygen being carried out to the body, CO2 being removed from the body. But here we're going to take a little bit deeper dive into it, and we're going to discover some things that we didn't know yet. All right. Oxygen is pretty easy, and it's pretty much exactly what we've already discussed. Okay, this one won't have any surprises to you, but oxygen, when it offloads from the alveoli onto the red blood cells, those erythrocytes, remember, inside of those erythrocytes is hemoglobin. And hemoglobin, if you remember, I told you, acts like it has a magnetic-like relationship with oxygen molecules. So when deoxygenated blood arrives at the alveoli in the lungs, that the hemoglobin in those erythrocytes acts like a magnet to help pull those oxygen molecules off of the alveoli and onto the red blood cell, oxygenating the blood to be carried throughout the body. Okay, so about 99% of oxygen is carried bound to hemoglobin on our red blood cells, like we've talked about. About 1% dissolves into the liquid portion of blood, that is our plasma. And then it can also still make its way throughout the body. But the vast majority is exactly like we've talked about before, bound to the red blood cells, carried by the red blood cells because of that magnetic relationship with hemoglobin. Okay, so now we're going to get into and just talk just on a real surface level about metabolism. When we come back from break, from spring break, we're going to get into the digestive system, and we're really going to get into the chemical analysis of how does our body break down, metabolize glucose and convert it to ATP. What are the chemical processes involved? Okay, the pathways of our body, our cells, breaking down glucose and converting it ultimately into energy, ATP, which it needs for survival and all cellular activity. The processes are glycolysis, the Krebs or citric acid cycle, and then the electron transport chain, also called oxidative phosphorylation. Okay, and again, we're going to get into all the chemistry involved. I know you guys can hardly wait, right? But we're going to get into that when we start talking about metabolism. So don't miss those lectures. Pretty important stuff to learn. But what's key to understanding is when our body needs fuel, remember our fuel is adenosine triphosphate, ATP. Okay, when our body needs ATP, we are breaking down glucose flowing around in our bloodstream. Glucose is a byproduct of the nutrients that we eat, carbohydrates as a first call. But we can also convert fats and proteins into glucose. Okay, we'll learn more about that with digestion. But ultimately, our cells, when they need energy and need to make ATP, which is they're always reaching out and breaking down glucose in one of these three pathways: glycolysis, the Krebs cycle, or the electron transport chain. And in order to convert glucose into usable ATP, fuel, energy, they use oxygen. So that's the reason, remember I've said over and over and over again, that our cells, tissues, and organs constantly need oxygen. I've never extrapolated on why do our cells need oxygen. Why they need oxygen constantly delivered is so that they can continue to break down glucose and make ATP. Because if they didn't do that, our cells wouldn't have any fuel. And much like our car without fuel, it would come to a complete standstill and all cellular activity would stop and our organs would shut down. So we need oxygen constantly. So there is a tremendous demand for oxygen. Now, as I also have mentioned many, many times, our cells need oxygen. And then also in our cellular activity, our cells in their processes of metabolizing glucose, along with many other things like making proteins or mitosis, all kinds of activities. They create waste product, and specifically those primary waste products of cellular activity are carbon dioxide, like I've shared over and over and over again, and then also hydrogen ions. Okay? All right. Carbon dioxide and hydrogen ions are acids. Okay? So when our cells go through their activity, their metabolism and other activities, and produce CO2 and hydrogen ions, our blood becomes more acidic. And remember what we talked about pH level of blood. It only takes a very, very minute, small change before we go into acidosis or alkalosis, and our organs start to shut down. Okay? So we don't have a lot of play here. Okay, so if we have during metabolic activity, normal expected metabolic activity, okay, we're going to produce CO2. We have to clear that out, or our blood's going to become too acidic and we're going to go into acidosis. Okay, so what I want you to know next is a term, and above it is what it is. Okay, and I'll explain why it's important to oxygen and gas movement. We'll talk more about glucose metabolism when we get to metabolism. But, and by the way, how our body corrects for this acid-like buildup. But just know that during regular cellular activity, as we can see here, metabolizing of glucose, which is constantly underway, we're making CO2 and hydrogen ions, which is making a condition called acidosis. Our pH number is going down. Okay, that increased plasma volume of carbon dioxide from the waste from cellular metabolism works to affect the relationship between hemoglobin and oxygen. Remember we said back within the lungs that the hemoglobin within the erythrocyte was really important because it acted like a magnet and helped pull that oxygen molecules onto the red blood cell. When we get out to the cell, that's great. So that's what draws oxygen onto the red blood cell. But then how does the oxygen molecule want to get off of the red molecule out at the cellular level, right? Why doesn't it just stay bound to the hemoglobin? And that's because of this CO2, this waste carbon dioxide in the plasma that is making the plasma volume a little bit more acidic. That weakens that magnetic relationship between the hemoglobin and the oxygen molecule, which causes the oxygen molecule then to let go and make its way into the cell. All right? And that process is called the Bohr effect, named after Dr. Niels Bohr, who was an award-winning physicist who won the Nobel Prize. Okay? So simply, the Bohr effect is cellular activity creates carbon dioxide, which you guys knew before we even started today. That carbon dioxide causes that hemoglobin oxygen magnetic-like relationship to weaken, and that allows the oxygen to jump off of the red blood cell and make its way into the cells out in the system. All right, so that's oxygen. How does oxygen get on? How does oxygen ride? And then how does oxygen get offloaded? We've talked about all those. Carbon dioxide is very different, and this one is unique. All right, carbon dioxide, remember, 99% of oxygen jumped onto the erythrocyte, 1% dissolved in plasma. With carbon dioxide, about roughly 10% of carbon dioxide dissolves in plasma itself, in the liquid portion of blood, and then returns ultimately to the heart and the lungs. Okay, about 20% of the carbon dioxide binds to the hemoglobin and the red blood cell itself. So in total, you can see that's only about 30% of carbon dioxide that is being transported in the method that was 100% of transport for oxygen. Okay, but about 70%, the vast majority of carbon dioxide is transported as bicarbonate ions, an alkaline, in our plasma. Okay? All right. So what are bicarbonate ions? Again, I shared they're ions that are alkaline. Okay? They form inside of our red blood cells from carbon dioxide and water coming on. Okay? And then there's this formation of bicarbonate ions. Okay? So out then in the systemic capillaries, okay, our bicarbonate ions are going to move into the plasma, and it's that bicarbonate ion going out into the plasma that's going to again threaten homeostasis of pH. Too much bicarbonate, too much alkaline headed out into the plasma from the accumulation of carbon dioxide and water is going to throw off pH. And therefore, chlorine will move into the red blood cell in an equal amount that bicarbonate ion moves out to balance the pH level back out, maintaining homeostasis. And that's called chloride shift. So another term, remember I told you at the beginning of today's lecture, you're going to need to know some terms for the exam. Know that chloride shift is the balancing of bicarbonate ions in our plasma by chlorine moving into the red blood cell, all with the intention of restoring and maintaining pH balance. That's called chloride shift, chloride going in. All right, and then I said earlier that we're going to talk for a minute about respiration and that the respiratory system is unique in that it's a unique system in that we can both voluntarily control it, and our autonomic nervous system for the majority of time makes it happen automatically where we're not consciously thinking about it. Okay, it all involves the brain as well as receptors. Okay, and when we want to voluntarily alter our breathing patterns, whether it's breathing faster, that's our respiratory rate, breaths per minute, or if we're breathing deeper, meaning we're exhaling more per breath and inhaling more per breath, those are voluntary changes that our higher brain, our cerebrum, our cerebral cortex controls. We can consciously think about that. For example, back to what I talked about during pulmonary function test. When the respiratory tech is telling you to exhale, you can voluntarily do that. That's our cerebral cortex voluntary, okay? But the majority of our breathing, our respiratory rate and depth of respiratory rate are controlled by our brainstem, specifically the medulla oblongata again, and our pons, okay? And these are going to come from a variety of feedback mechanisms coming to the brainstem, receptors, things like chemoreceptors in our arteries that are constantly measuring pH and oxygen levels, and carbon dioxide levels, among other things, and sending signals to the brain, all to maintain homeostasis. Receptors in our muscles. For example, if I start to exercise and I start to jog, my leg muscle receptors are going to send a signal to my brainstem, which in turn is going to send a signal to my lungs to increase my respiratory rate, to bring in more oxygen and air from the outside environment because my muscles down here in my legs need more oxygen, right? So the receptors send a signal to the brainstem, which in turn send a signal to the lungs. Okay, and then sometimes even stretch receptors within the lungs themselves send a signal to the brainstem, which alters respiratory rates. All right, but of all the things that affect the rate, which is the breaths per minute, and the depth, which is the amount of gas we inspire or expire, by far the most important are chemical factors, okay? And we introduced those back here with the chemoreceptors within the arteries, okay? It's those chemoreceptors in our arteries that, like I said, are constantly measuring the amount of plasma-based carbon dioxide, which we heard about, plasma-based oxygen levels, which we heard about, and pH levels, which we've talked about, that are the most important at changing the level of respiration, how deeply and how fast we breathe. Okay, and it's all about restoring and maintaining homeostasis. Think about if you're sitting here right now during this lecture, and in 3 minutes when we're done, you get up and walk to your kitchen. Your body, just from doing that, is going to have a rapid change in oxygen requirements, the amount of oxygen that you need to walk. You're no longer sitting at rest. So your receptors in your arteries are going to detect a drop in your plasma oxygen levels. They're going to signal your brainstem, which will signal your lungs, and unconsciously your lungs, you will start to breathe a little bit deeper and a little bit faster to bring in more gases from the external environment to meet demands of walking. Okay? These are the most important factors of influencing breathing, are chemical receptors. And that's it for today, guys. That is it for content for the respiratory system. Do we have any questions on what we covered today in respiratory physiology? I hope that my analogies and trying to break things down and my precursor lead in with the scientific concepts made this a little bit easier to process and understand. That is, trust me, with 100% sincerity, that is always my intention, is to try to take difficult content and transpose it into something that's digestible and maybe a little bit more understandable to you, the end user, okay? So hopefully that was the case. Of course, it absolutely is always my goal. As you guys start studying for this exam, if you run into difficulties, by all means, email me with questions. I'll be happy to answer your questions, clarify anything that needs clarifying. Remember, as always, my presentations are your ultimate study guide. Study my presentations and you will do exceptionally well on exam number 2. Study day next Tuesday, next Thursday, 8 a.m. to 8 p.m., lecture exam 2. The next week is spring break. And like your calendar shows, we come back for lecture on Tuesday, March 17th to start the digestive system. I will send an email out to you guys, most likely on Sunday, just as a reminder that while we don't have lecture, we will be meeting still at 2:20. We'll just move lab forward because we have a respiratory lab on Tuesday. Always consult both calendars. That's why you have 2 calendars, one for lecture, one for lab. Okay? All right, guys. So listen, I won't see you guys back here. Well, I guess I will see. Yeah, I will see you guys. I'll see you guys for lab on Tuesday. So in this case, for all my other sections that I don't have for lab, I had to wish them a healthy and safe spring break. But for you guys, I'm going to see you guys on Tuesday for lab. So we'll see you Tuesday at 2:20 for lab. In the meantime, start studying for this exam so you guys can really knock it out of the park on Thursday. See you Tuesday. Have a safe weekend. Bye, everyone.